Welcome, everybody, to today's episode of the NAPC podcast. I am absolutely delighted today to have in the room Nigel Edwards, who is going to talk to us about all things population health, neighbourhood care, care models, and drawing on his sort of vast experience. We're going to have a discussion about where we are, what works, and how you actually get some of this to happen, most importantly. Nigel. You've had a front row seat on system transformation in health and care for decades. What draws you now to think that, the focus needs to be on neighbourhoods and integrated teams that sit around them?
Well, I thought for a very long time that the sort of big error that Bevan made in establishing the NHS was there being so much emphasis on things being national and nationally determined. Other NHS systems in Europe have often gone down a different path and have put much more emphasis on sort of the regional or even municipality sort of local level. Even some of our current ICBs are the size of EU countries in population terms. So we still remain very centrist. So I think the first lesson is that we need to be very clear what definitely needs to be determined nationally. Do once. What's in the category of adapt and adopt, and what's in actually this is about local determination and needing to work it out. And we're massively confused about that. So Spain, for example, has a single method for risk stratification across all of its 17 autonomous communities. We've probably got more than 17 in London, I would guess. Why would you not centralise that? Why is everybody doing data sharing agreements locally when they could be done nationally? And then there's people doing things locally, which doesn't speak to the NHS app, which apparently is fine. So I think the first lesson here is we need much more clarity about what is local and what is national. When we do this, we do far too much which is national, and for the local, we're often not clear enough about what the design rules are. So that's the first lesson, I think. The second lesson is that we're also very poor at prioritisation and working out what we can actually do within the resources that we've got. My experience in other countries which are sort of fiscally challenged, like ours, is you've probably got space to do 5 or 6 things. You don't have space to do 150. But that means locally, people really need to be very rigorous about actually working out what's important and doing it. And then I think the third lesson from internationally and particularly in the NHS is, I think it's called Hofstadter's law, which is everything takes longer than you think, even accounting for Hofstadter's law. There's just an elapsed time thing, particularly for those changes which require changes in work processes or the establishment of new relationships. And I'm afraid that the history suggests that the people making policy have been very bad at understanding those 3 really important things.
That's sparking so many questions for me in my head, because the priorities thing. So one of the things I observe endlessly is they talk about 150 priorities, but actually there's only one, and it's called the UEC programme in most systems. And it's actually about the edges of the flow through a hospital. It's often not even about the flow in the hospital, but the edges of the flow between the two. And that seems to consume the vast majority of thinking time, clinical and managerial leadership time. So I'm sort of going slightly off script here, because what's intriguing me is how you genuinely put some thinking into priorities and then take the resources that you have, both leadership and frontline delivery, financial, but largely it's people, and follow through on doing something about those priorities.
Yeah, I mean, it's quite hard to develop a policy prescription for that, frankly. I mean, quite a lot of that, when you look at the systems who do seem to be able to do this, it is quite a lot about the quality of the senior managers and their ability to kind of create a bit of an umbrella over their local systems to say, right, they have to deliver the UEC agenda because it's, and indeed elective weighting, but they seem to purposefully also work on these, create some space to work on these other issues. And I don't know if there's an easily bottleable formula for that. And it's, of course, quite a few examples that one might cite. The sort of Jim Mackey's and Glenn Burley's and others of this world do often start from the advantage of systems that are kind of working already. The difficulty particularly is for people who are already underwater, where they don't manage to sort of earn the space. But quite a lot of this is actually about the senior managers holding the line and saying, no, actually, we know we are going to make a big focus on neighbourhood health or population health or health improvement or whatever, or whatever our 2 or 3 current priorities are. We'll fix UHC over here, but we're not going to let it drown out the things that actually are important for the longer term.
I actually think it does come down to local system leadership. So your sort of borough-based, your municipal leadership as well, because I think it's quite hard to have a formula from that on high. Again, I think that's one of the sort of you need local leaders. And one of the things I observe about the NHS is that we seem to have completely dropped any sort of leadership development at any level. And I think that in order to deliver, albeit Hofstadter's law says it's going to take longer than we think it's going to take, so much of this is about the leadership at, I guess, what you could the sort of municipal ICB level, but then actually I think it's the leadership below that level that's critical. Yeah. And it needs that adaptive, different style of leadership. And for me, the lever I don't think we've been putting for at least the last 5 years, maybe longer, is around developing our leaders, really putting investment into developing our leaders, which would allow them to think through that challenge of how you deliver urgent emergency care at the same time as 2 or 3 other priorities, and don't drown yourself out with a spreadsheet.
Yeah. Absolutely. I was very struck. I was in a conversation yesterday in which the current acting chief executive made a very interesting observation, which was, we've got 11 local authorities we have to deal with to try and get our flow sorted out. There's several upper tier ones that we're dealing with, but we've developed relationships and got a sense of common purpose. That's actually meant we've managed to streamline all of our discharge arrangements between the different authorities, and we have made significant progress on flow. And that's about long-term relationship building, as well as the technical skills of leadership. So I think there's something also about, just slightly concerning in the current context, people in post for reasonable periods of time with the right skills to develop relationships, and not a situation where the people that you're dealing with think, well, you're having these conversations with me, but I do know that NHS England can ring you up at any moment, pull you out of this meeting, or distract you from the thing that we're all agreeing on. So I think there's a combination of soft technical skills, which sometimes we're also missing. There's been a lot of development of those over the period I've been in the NHS. When I started, most management didn't consist of any technical skills at all. It was all, but it was all about relationships. I think the relationship bit we perhaps have needed to rebuild, but you need both of those things in place. And the particular risk here is that the middle managers in these systems see their job as defending the territory and the boundaries of their bit, rather than solving other people's problems. So there is quite a flip required in quite a lot of the sort of the standard and quite understandable sort of socialization that middle managers have about exactly what their role is and how they relate to the rest of the system.
That's a really good point, because I would say often that is the barrier that gets in the way. These poor people in the middle management jobs just get accused of being the block to any transformation and change, and by the front line they get accused of managing the money too tightly and not understanding the real issues of being a clinician or a practitioner on the front line. So creating a permissive culture, I think, is another of the big strands that I see that's changed. I even hear chief execs and boards say to me, we haven't written our strategy yet because we're waiting for the guidance that tells me what needs to be in the strategy. So the whole permission to lead and to take on your role sits, I think, for me in that sort of leadership development space. But it's such a big culture to shift, because that silo piece, and that you do what you're told and you don't do anything else, is now such an ingrained set of behaviours. Shifting that type of behaviour is not going to, it's probably in Hofstadter's law as well, because it's not going to change overnight. You don't change a behaviour. You have to invest in shifting that behaviour. When you're doing it across organisation,
that becomes particularly difficult. So I think over the next few months, as we start to see what the shape of the new DHSC, NHS England arrangements look like, and the nature that there has been some attempt to try and reduce the number of targets and priorities, but there's still very strong rhetoric of being tough, which you kind of understand. But I think the challenge is, if you want a neighbourhood-based system, but you're running a national service, It's a paradox, right? I mean, we're going to have a national plan for neighbourhood health. Well, how does that work? We're going to have national. I'm going to be tough on management, and I'm going to drive performance. But actually, I want more standardisation. I want to reduce variation. But these are really subtle and tricky paradoxes that need to be worked through. Right? I mean, we don't have the right level of standardisation, absolutely. But working out which is the right, what should be standardised and what shouldn't, and and then doing the standardisation bit. Just a very interesting example came up in the conversation yesterday was the public engagement with Londoners says we want a standard way of accessing general practice. It can't be the case that every single practice has a different method. It all ought to be roughly the same, right? Which is fair. I mean, actually, I'm not sure any other business which had 500 million encounters with the public would not have some form of standard method for doing it. So they can see that. But just think about the leadership, management and effort that will be required to do that. And the subtlety of thought that's going to be needed to work out what is important to standardise in that and what can be left to local practices. Very tricky. And I'm not sure we quite know how to do that. And again, that's going to be one of the reasons why, it's going to take longer than we expect, and B, there's going to be some false starts, and it will be a bit rough around the edges as we're doing it. And again, we're not very tolerant of that, I think.
That was what was running through my head, actually, as you were speaking, is I think one of the other traps we fall into is thinking you can describe perfect and then a perfect linear path to get to it. And that is not what we're describing here. And how does a system have the confidence to just get on and do something, even if we actually don't know exactly what the end's going to look like? Yeah. Because the things you're talking about are huge. Even an understanding of what you do once, one single risk stratification system across the whole country is huge. You can imagine that burying large numbers of people for years. So how do we take steps onto a journey that we sort of vaguely know is going in this direction, but we're not quite sure exactly what the right ones are, and don't just create paralysis, which is what I think I observe a lot, a paralysis of waiting for the perfect answer.
Yes. Well, sometimes the opposite, which is rushing off and buying your own 5-year license on a system that actually, isn't going to work with anyone else's. So we're back to this question about what's the right place to take the types of decisions we need to take, and what are the right processes for making those decisions. So, if we go back to risk stratification or data sharing agreements, or that seems to me to be one thing where, following this Spanish example, one would just go for risk stratification or segmentation. We're going to buy X, right? We'll buy Johns Hopkins. If you want to use your own as well, that's fine. But actually, we expect all your data to come back to us in ACGs, right? And we'd like to see your processes using it where possible. You could do that quite quickly, but we'd probably set up a 2-year process to think about it. So I think being clear about what's central, how quickly do you need to make the decision, and then actually just getting on with it probably is something that needs to be thought about at all levels of the system.
In my head at the moment, there's a slightly more fundamental question as well, is whether is the evidence there, and do people really believe that if you enable people to improve their health through the 4 core interventions everyone knows, sleep more, eat better, move more, meaningful purpose and connections, it will reduce demand on acute services? Because everything we focused on in the last decade has been at the end of the journey on acute demand. And I guess this thing that revolves around my head as I go around talking to people is, it's easy to say, but if you were really talking at the heart of the matter, do we think that the evidence backs this up and that people believe if we shifted our focus to neighbourhood-based teams enabling people to live healthier, it will reduce demand on acute services? Because I think that's what drives the constant crisis management, if I'm honest as well, that there isn't really that belief there.
Yeah, and to be honest, the evidence is partial, right? I mean, it's not bad in a number of ways. I think one of the things that we've learned, and this maybe, I don't know if it's in people's minds, is that where there is evidence, the question about our capability of replicating the approach that produces that is a bit of a worry, isn't it? Because one of the very striking things with a lot of these interventions is if you only do 90% of it, it doesn't work. There's a kind of Pareto thing, right? You've really got to do the thing with the active ingredient in it that works and do it well to get anything like 90% of the result that's in the research evidence, right? So the skill of execution of these things, I think the author G.K. Chesterton once said, if something's worth doing, it's worth doing badly. Lots of these models don't work well if they're done badly. They don't sort of partly work. They do need skill in execution. And I think that's probably one of the things that people have found out over the years with, the replicability of many of these integrated care and multidisciplinary care team models is that they've often produced quite disappointing results. And that's often because it's just not been really skillfully implemented. So I think that's probably behind quite a bit of the nervousness, is that people are maybe a bit aware that while there is evidence, there's quite a lot of evidence for all of this, putting the services in place that do deliver it. A culture shift among some clinical professionals who have a different view of sort of worldview of these issues to be thinking more like that are all quite difficult to do, and people have been through other types of attempts to implement new models of care, which often have not quite produced results that everyone hoped, or in some cases actually made things worse by creating additional demand that lies behind some of the nervousness, I think.
So you walk into a system, Nigel, you do that every day, or at least every week, and they're struggling with the complexity. Where do you start? What would you advise them? Where do they start?
Well, I think the very interesting piece of work I did with NAPC, sort of learning from your experience in this space, is as you start with the frontline clinical staff and start to think about how they work and how you can help them work in more effective ways. That starts to build their team working, helps them to understand the population health data that's available that can help them think about how they target their efforts, to support them in designing some of the new ways of working and systems and processes, and to some extent start bottom up, assuming of course you've got a clear idea of what you think the end point in terms of outputs and outcomes is going to be. So you've got a story to tell about, this is where we're trying to get to, which is about improving population health and well-being, getting to be more proactive, being more effective at prevention, tackling inequalities. So that high level vision, but the actual nitty-gritty needs to, I think, be a lot based on people learning by doing and building, having the time and support to do some of this stuff at a much more local level than we've tended to do. So, you probably do need to get everyone together in a room and do those sort of big workshop things, but actually that's not where most of the action is. And I think we have those big meetings, and not much happens in between them. But I think the should shift the focus so that more of this is about people in MDTs having actual time to sit back and go, well, let's try this new thing. Let's try this new system. Here's a new member of staff we're going to bring in. So all the evidence on ARS types roles, for example, both in this country and in the literature, is the time and effort to do the design to integrate new models of delivery and integrate new members of staff is quite significant. Generally, we don't give anything like the level of support and time that people need to be able to do that. Then we're surprised it doesn't work as well as it might, and that people aren't clear about what their role is and how they fit into the system. So I'm increasingly thinking that sort of processes of local experimentation and learning supported by people who've got change management and facilitation skills to help them do that. Local community practice, just so that people don't have to entirely invent new ways of doing things, combined with this clarity about what are you designing and what are we going to mandate, because actually we are going to have a single system of GP triage across the whole of our ICB, or whatever whatever you've decided. I think that's what I took from some looking at the lessons from the work of the NAPC have been doing, and from other experiences in this space.
And I guess the sort of final thing I want to ask is, as we started with, you've been developing the thinking on this and been involved with systems over many years, as I. Is it different this time? Do you hold more hope that we might actually get on and shift and get some of this right and create some longevity out of it this time round? Or are we just waiting on the next policy reform that reverts us again? More hope this time or not?
I think there's reason to be optimistic. I think more people who understand the importance of population health and how to make that happen, who get the need for a multidisciplinary, large sort of approach to primary care and the centrality of primary care in delivering much of this agenda, of improved relationships and ways of working with local government, which also is reason to be encouraged. The thing that makes me more pessimistic is, first of all, these types of big changes do require resources, and we're short of both time, people's time and money to support the change process. The second is the experience of these types of plans and some of the people who are involved in developing them is that they tend to be very ambitious in terms of having a very large number of things to do, and actually we need to focus. And they also tend to be poor on how it's going to be done, which on the upside means that there's the scope for people to develop local solutions. But on the downside, given the culture that we were talking about earlier of people waiting to be told, is perhaps a real concern about whether we actually have the mechanisms to make some of these changes happen. And I think there is a sort of fundamental question about where decisions need to be taken, and an instinct to try and centralise decision making, to tell people what to do, which stifles initiative, reduces everything to the lowest common denominator, often introduces a culture of overly aggressive performance management and, if not actual bullying, and that tends to too often focus on the short-term objectives around emergency care and electives rather than the longer-term goals of improving population health.
Thank you. I think we could probably discuss this matter for days on end, not just today. I thought I'd just try and pull out a quick summary of the sort of top 5 things I've heard you say, because they've really helped me. And I think that first thing about really understanding what you do once and what you do local is absolutely critical. We're getting it wrong on both counts. We're doing things that should be done local once, and we're doing vice versa. We're not just nailing the stuff that should get sorted out once. So the energy probably in the centre needs to be at that much more macro scale of what do you do once and what you do local. I love the example that even in a complex environment with multiple local authority boundaries and potentially provider boundaries, you can work your way through the relationships, but it takes time and it needs continuity of leadership. This is going to take headspace and time for the frontline teams, and not underestimating it. I mean, I go further than that. I hear that it's just not even seen as acceptable to have a conversation with each other. Like, you have to just crack on. So changing that cultural shift that says this is about time, headspace, and that will need skilled coaching and facilitation to overcome the barriers is another point. Then there's something for me about the sort of middle tiers of management that we have trained to take instruction and then deliver and hold to account, to the point of very extreme performance management both ways. That needs some really thinking about how do you shift to a more adaptive style of leadership and an adaptive, permissive culture. But I guess the final bit is where you ended that, and I'm with you on this. There does seem to have been a perceptible shift in the people seeing this as the long-term solution for both an affordable and a better quality and better outcome-based national health service for this country. So that gives hope that sort of is gone from the zealots at the front saying, why aren't we doing this differently, to a much more mainstream set of thinking, if only we could find the time to do it. And that lies the leadership challenge. Nigel, thank you very much, and thank you for helping us keep on track on a subject that I know I can meander on for some time. So thank you very much.